Stop before you do anything else. Find the nearest mirror or flip your phone camera toward your face. Look at the whites of your eyes, both of them, in a strong light. Really look. Most people have not done that in years. They have glanced. They have checked for redness after a bad night, but they have not looked the way I am asking you to look right now, because nobody ever told them what to look for. I have been practicing internal medicine in northern New Jersey for over 25 years, and what I am about to show you is something I use in the exam room every week. It takes 30 seconds. It asks nothing of you except attention, and it has changed outcomes for patients who had no idea anything was wrong. Number 4 on this list is the sign that has sent patients to emergency rooms once they finally understood what they had been looking at for months. Most of them had blamed a long week. Number 7, the one the thumbnail warned you about, takes 3 seconds to check. It has caught strokes before they happened. Both of those are coming. Do not leave before we get there. My name is Dr. Elena Russo. I am an internal medicine physician, and I have been seeing patients in New Jersey for over 25 years. Before we go through each sign, you need to understand why the eye surfaces so much information at all, because it is not an accident. The white of the eye, the sclera, is a thin, relatively avascular membrane. Unlike the skin on your face, which sits over layers of fat, muscle, and melanin that filter signals from the bloodstream, the sclera is stretched directly over a dense network of small blood vessels with almost nothing between them and the surface you can see. Changes in what that blood carries, bilirubin, hemoglobin, lipids, inflammatory markers, become visible here before they register anywhere else on the body's surface. The conjunctiva, the transparent membrane covering the sclera, is one of the most accessible capillary beds in clinical medicine. Emergency physicians use it to assess circulatory status and hepatic function for exactly this reason. It is precise, immediate, and requires no equipment. The eyes often signal disease days or weeks before a standard blood panel catches it. Not because the disease is worse, but because the eye is more sensitive. 7 signals are visible there right now. Some are subtle. One of them looks so harmless that patients have been reassured about it for years by people who should have known better. Before we go through all 7, when did you last actually look at the whites of your eyes? Not a glance. Really looked. Tell me in the comments. I want to know. Sign number 1. Look at the outer edge of your iris, the colored part of your eye. Do you see a thin, grayish-white arc along the outer rim? In some people, it is a partial arc, appearing at the top or the bottom. In others, it forms a complete ring encircling the entire iris. Most people who have it know they have it. Most of them have been told it is a normal sign of aging and left it at that. Sometimes that is true. After 70, a complete corneal arc is common enough that it carries less diagnostic weight on its own. But here is what almost nobody explains. The same finding in a person under 60 is a different clinical story. What you are seeing is lipid. Specifically, deposits of LDL cholesterol and triglycerides that have precipitated into the outer tissue of the cornea. The cornea has no direct blood supply of its own. It is nourished by vessels at its margins. And when lipid concentrations in the blood are chronically elevated, those marginal vessels become a deposition site. The outer corneal tissue begins to accumulate what the blood is carrying in excess. Published research in the British Medical Journal and elsewhere has consistently linked corneal arcus in patients under 50 to significantly elevated LDL and increased cardiovascular risk. After 60, a partial arc, one that has not yet formed a complete ring, still warrants a conversation about the last time a full lipid panel was done. If you have not, that is your action. Not an optometrist visit, a lipid panel. Sign number 2 is a growth that most people have been told is a cosmetic problem. Sometimes that is accurate, but behind some of them is something metabolic. Something the body has been trying to signal for years before anyone looked closely enough to see it. Sign number 2 is easier to find. Look at the white of your eye on the side closest to your nose. Do you see a slightly raised, yellowish-white, triangular or oval patch sitting on the surface? In some people, it is small and almost translucent. In others, it is more pronounced. It does not hurt. It does not interfere with vision in its early stages. Most people have been told it is simply the result of sun exposure. And that explanation is not entirely wrong. The standard mechanism is ultraviolet-induced degeneration of conjunctival tissue. The elastin and collagen fibers break down under years of sun exposure, and the deteriorated tissue accumulates into a visible deposit. That explanation is accurate as far as it goes. What it leaves out is this. Emerging research links rapidly growing or recurrent cases to markers of chronic systemic inflammation, elevated C-reactive protein, and metabolic syndrome components. When a pinguecula extends onto the cornea itself, becoming what is called a pterygium, the clinical associations broaden further to include vitamin D deficiency and accelerated age-related tissue breakdown. The growth is not the disease, but it can be pointing toward one. A pinguecula that has been stable for years is monitored, not urgently treated. One that has visibly grown or changed color within the past 6 months warrants evaluation, along with a C-reactive protein level and a basic metabolic panel. Sign number 3 is the most alarming-looking finding on this list. People see it and panic. But the danger in it is not what they think it is, and the pattern within it changes everything. Sign number 3 does not require careful examination to spot. It announces itself. A bright, sharply defined red patch on the white of the eye, not diffuse redness, not the generalized pink of tired or irritated eyes, but a pool of blood, vivid and contained, appearing suddenly, often overnight, often without any explanation the patient can identify. A small blood vessel in the conjunctiva has ruptured, and blood has spread beneath the transparent surface. It looks dramatic. It is almost always painless, and it is one of the most frequently mismanaged findings in outpatient medicine. A single episode with a clear mechanical cause, heavy lifting, prolonged coughing, a forceful sneeze, straining, is almost always benign. The blood reabsorbs in 1 to 2 weeks. That is not the finding to focus on. The finding to focus on is the one that comes back. Recurrent episodes appearing 2 or 3 times over a period of months without any obvious physical trigger are a documented vascular marker. Uncontrolled hypertension is the most common underlying condition. The small vessels in the conjunctiva are among the first peripheral vessels to show the strain of chronically elevated blood pressure, and they rupture in patients who feel entirely well because high blood pressure rarely announces itself through symptoms until it has been elevated for a very long time. Anticoagulant medications, including warfarin, apixaban, and rivaroxaban, dramatically increase the risk of spontaneous hemorrhage, and a recurrent red eye in someone on blood thinners can be the first sign that the medication level has gone too high. I think of Margaret, 67 years old, a retired librarian from Columbus, Ohio. She woke up with a completely red eye 3 times over 4 months. Her husband thought it was the air conditioning. She came into the office. Her blood pressure was 178 over 102. She had been entirely asymptomatic. She had no idea anything was wrong. Her words when I called with the full workup results? I felt completely fine. I thought my eyes were just sensitive to something in the house. 1 episode after a clear physical cause. Watch it. It will resolve. 2 or more without explanation. Check your blood pressure that day. And if you are on any anticoagulant medication, call your prescriber before your next scheduled visit. Number 4 is the sign that gets people to the emergency room once they finally understand what they have been looking at. And it starts with a color most people blame on a long week or a glass of wine. Sign number 4 requires natural light. Not your bathroom, natural daylight, or a strong white light if you are indoors. Look at the outer corners of the whites of your eyes, not the center, the corners, and look for yellow. A shift toward amber or gold in the scleral tissue. This is called scleral icterus. It is one of the earliest and most reliable physical signs of jaundice, and it appears in the eyes before it appears anywhere else on the body. Before the skin changes, before the face yellows, sometimes days before any other visible sign surfaces. The mechanism is this. Bilirubin is the breakdown product of aging red blood cells. The liver processes it and eliminates it through bile. When the liver cannot keep pace, in hepatitis, in cirrhosis, in bile duct obstruction, in hemolytic anemia, bilirubin accumulates in the bloodstream and deposits in tissue. The sclera has an unusually high affinity for bilirubin. It binds to elastin fibers in the scleral tissue, which is why the eye changes color before the skin does in most patients. Here's the clinical subtlety that almost nobody explains. The yellowing is most visible in the outer corners of the sclera, in natural light, with the eye relaxed and open. Patients checking in bathroom mirrors under incandescent light, looking at the center of the eye, miss early scleral icterus regularly. They are looking in the right place but under the wrong conditions. If you see yellow in the outer corners of your whites, in natural light, that is a liver function test today. Not this week, today. Number 5 was the sign that surprised me after 20 years of practice. Because what looks like a simple inflammatory reaction in the eye can be the first protest from a disease that is simultaneously attacking the joints, the kidneys, and the lining of the heart. Sign number 5 requires you to look more carefully, because the difference that matters here is subtle. Look at the white of one eye. Is any redness present? And if so, is it spread across the whole white evenly? Or is it concentrated in one sector, a defined wedge or patch of deeper red or pink in one location, while the rest of the white looks normal? Diffuse redness across the whole eye, both eyes, often with discharge, is almost always conjunctivitis. Common, contagious, treatable. That is not what we are looking at here. Sectoral redness, a localized area of inflammation in one part of one eye, without significant discharge, sometimes with a dull tenderness when you press gently on the closed eyelid over that spot, is a different finding entirely. It is called episcleritis when the inflammation sits in the tissue layer just beneath the conjunctiva. When it goes deeper into the wall of the sclera itself, it is called scleritis. And scleritis is painful in a way that episcleritis typically is not. Both are documented markers of systemic autoimmune disease. Studies in rheumatology have found that roughly 40 to 50% of patients presenting with scleritis have an underlying systemic condition on comprehensive workup. Rheumatoid arthritis, lupus, inflammatory bowel disease, and ankylosing spondylitis are among the most common. The eye inflammation is frequently the first visible protest of a disease that has not yet reached the threshold of joint pain or organ symptoms the patient would recognize as medical. The detail that gets missed. This is routinely misdiagnosed as conjunctivitis. Conjunctivitis is diffuse and bilateral and contagious. Episcleritis and scleritis are sectoral and unilateral. They do not respond to antibiotic drops. The distinction is not cosmetic. It is the difference between another useless course of antibiotics and an accurate diagnosis. I remember Robert, 71 years old, a retired electrician from Phoenix, Arizona. He had been treated for what his general practitioner called pink eye 4 times in 2 years. 4 courses of antibiotic drops. No improvement on any of them. He came to me certain he had developed an allergy to something in his garage. He had no allergy. He had early rheumatoid arthritis. His joints had barely registered symptoms at that point. The eye had been protesting for 2 years, and every visit had produced the wrong response. His words at his rheumatology follow-up, 6 months after the correct diagnosis. I would never have connected those 2 things in 100 years. Sectoral redness that has occurred more than twice, that does not respond to standard drops, or that comes with any tenderness when you press on the closed eyelid, that is a rheumatology referral, not another antibiotic. Number 6 is the sign you check without a mirror. I am going to show you exactly how. And in some patients, it has been the only visible evidence of internal bleeding that had no other symptoms. Sign number 6 requires one action. Pull down the lower eyelid of one eye, gently, with the tip of one finger. Look at the inner surface. The conjunctiva lining the inside of the lower lid should be a clear, healthy red-pink, the same color as the inside of a lip when pressed open. If what you see is pale, whitish, or barely pink, that is conjunctival pallor. The test takes 5 seconds. Most patients have never done it because nobody ever told them to. The color you are looking at is a direct readout of the capillary hemoglobin concentration in that tissue. When iron falls, when B12 drops, when the body is losing red blood cells faster than it can manufacture them, the signal appears here early. Hemoglobin concentrations below 10 grams per deciliter are frequently visible in the conjunctiva before breathlessness has become pronounced. before fatigue has become severe enough that the patient describes it as a medical problem rather than tiredness. Clinical studies have demonstrated that conjunctival pallor has high specificity for anemia. When the inner lid is pale, hemoglobin is almost always low. Here is what the standard explanation almost always leaves out. In adults over 65, iron deficiency anemia is frequently not a dietary problem. It is frequently caused by slow gastrointestinal blood loss, from a peptic ulcer, from a polyp, from early colorectal cancer. Conjunctival pallor in an older adult is not a nutritional consultation until proven otherwise. It is a gastrointestinal investigation until proven otherwise. I think of Helen, 74 years old, a retired nurse from Portland, Oregon. She had been self-managing fatigue for 2 years before she came in for something unrelated. She was not concerned about her energy levels. She had simply decided that was aging. Her lower conjunctiva was paper white when I looked. Her hemoglobin was 7.8. She had a colonoscopy 2 weeks later. The finding was a precancerous polyp, not yet malignant, but close. Caught at exactly the moment it still could be fully removed. Her words afterward: "I was a nurse for 30 years. I knew something was wrong. I just kept looking in the wrong places." Pull the lower eyelid down right now. If the red pink is absent or significantly faded on both sides, that is a complete blood count, not a vitamin recommendation. How many of you just tried that for the first time? Tell me in the comments what you saw. Pale, pink, or not sure? I want to know. The last sign on this list is the one the thumbnail warned you about. If you see it, you do not wait for an appointment. I am going to tell you exactly what to do. Before I describe it, I need to draw a clear line. There are situations where what you see in or around your eyes is not a signal to monitor. It is a reason to call emergency services immediately. Stop this video and seek emergency care right now if any of the following apply. A sudden change in the size of one pupil that was not present yesterday. A drooping eyelid that appeared in the last 24 hours. Any sudden change in vision, including blurring, double vision, or loss of vision in one eye, especially if accompanied by a headache, weakness on one side of the body, or difficulty speaking. Do not drive yourself. Do not call the office first. These are stroke symptoms until proven otherwise. Sign number 7. Look straight ahead into a mirror or your phone camera. Look at your pupils, the dark circles at the center of each eye. Are they the same size? Now look at your upper eyelids. Does each one open to the same height? These two questions take 3 seconds. Emergency neurologists call this the ocular neurological screen, and it is part of the initial assessment of every patient with suspected stroke or intracranial pressure change. You can run it at home right now. The pupil is regulated by 2 competing nerve systems, the sympathetic and the parasympathetic. Both travel through or in close proximity to critical anatomical structures: the brainstem, the carotid artery, the oculomotor nerve at the base of the brain. When something disrupts that balance on one side, the asymmetry becomes visible. A sudden change in pupil size on one side, not a difference that has been there for years, but a new asymmetry, can indicate Horner's syndrome, a disruption of the sympathetic nerve chain producing a smaller pupil and a drooping upper lid on the same side. The cause can be a carotid artery dissection, a tumor at the apex of the lung pressing on the nerve, or a brainstem stroke. A dilated pupil on one side that does not constrict normally in bright light, especially accompanied by a drooping lid on the same side, is a classic presentation of pressure on the third cranial nerve from a posterior communicating artery aneurysm. This is one of the few warning windows before aneurysm rupture, an event that carries a mortality rate above 50%. I want to address one thing before it becomes a concern. Approximately 20% of the healthy population has benign anisocoria, pupils that have always been slightly unequal, a lifelong variation that is completely harmless. The word that separates that population from the one I am describing is new. New asymmetry is not the same as long-standing asymmetry. A photograph from 6 months ago is objective, useful context. Many people have one on their phone right now. Check your pupils today. If you can find a photograph from the past year, compare. If the difference is new, and if there is any accompanying headache, any visual change, any facial weakness, that is an emergency room, not a phone call to the office. 3 seconds. Every time you happen to see your own face in a mirror. Here is what to do with everything you just learned. A practical system. 6 steps. 30 seconds. Once a month. Step 1. Light. Natural daylight is ideal. A strong white LED lamp is acceptable. Incandescent bathroom bulbs distort yellow tones and wash out pallor. In the wrong light, you miss early scleral icterus. You misread the pallor test. Do this check at a window or step outside. Step 2. The color of the whites. Look at the outer corners, not just the center. Pink and clear is normal. Any shift toward yellow in the corners, liver function test. Uniformly pale or grayish-white across the surface. Note it and continue to step 3. Any localized sector of redness, not diffuse, that has appeared more than once. Rheumatology referral. Step 3. The pallor test. Pull the lower eyelid down gently. Healthy red-pink is normal. Pale or whitish on both sides. Complete blood count. Not a vitamin. Step 4. Pattern versus diffuse redness. Both eyes red with discharge. Conjunctivitis. One area of one eye, localized, recurring. A specialist referral, not another antibiotic. Step 5. Surface structure. Any raised yellowish growth on the white of the eye? Has it visibly changed in size or shape in the past 6 months? Growth within 6 months. Evaluation and metabolic panel, not watchful waiting. Step 6. The pupil check. Same size on both sides. Both lids opening equally. Compared to a photograph from the past year if you have one. New asymmetry accompanied by any symptom. Emergency evaluation. Do this once a month. Photograph the result. Your phone camera is sufficient. In 6 months, you have a baseline. In a year, you have a clinical timeline you can show any physician you see. If this gave you something you did not have 30 minutes ago, send it to one person you care about. Your partner, your sister, a close friend. That one share might matter more than you realize. I want to tell you about Carol, 69 years old, a retired school teacher from Albany, New York. She came in for a routine prescription renewal. No new complaints. She felt well. We were talking, and I happened to glance at her lower eyelid as she was speaking, the way you do after enough years of practice, where the physical exam becomes part of the conversation rather than a separate event. Her conjunctiva was white, not pale, white. Her hemoglobin was 8.1. We arranged a gastroenterology referral within the week. The colonoscopy found a lesion. Precancerous, stage 1, not yet malignant, but advancing. Fully resectable. Clean margins, no chemotherapy, no radiation. She went home and resumed her life. 6 months later, she came back to the office for follow-up. She looked well. She was well. And she said something I have not forgotten. You found it in my eye. That is exactly right. Not on an imaging study she had not yet been ordered. Not on a blood panel that had not yet flagged. In her eye. In a tissue that had been quietly telling the story for weeks before any other signal had surfaced clearly enough to act on. The whites of your eyes are not cosmetic. They are not a reflection of your sleep quality or what season it is. They are a reporting surface. The body uses them to broadcast what the liver is doing, what the blood is carrying, what the small vessels and the immune system are doing. It does not stop reporting because nobody is reading. Tonight, before you go to sleep, find a mirror and a good light. Pull the lower eyelid down. Look at the outer corners of the whites. Check the pupils. 30 seconds. There is no billing code for what you just learned. A standard physical exam rarely includes any of it. The system is designed to treat you when you are sick. What you do in 30 seconds before that happens is yours. 7 signs, 30 seconds each. 1. A gray or white arc along the outer edge of the iris. Lipid deposits, cardiovascular risk. Lipid panel if you have not had one in 12 months. 2. A raised yellowish patch on the white, visibly grown or changed in 6 months. Metabolic evaluation, including C-reactive protein. 3. A bright, defined red patch appearing without clear cause, more than once. Blood pressure check immediately. If you are on anticoagulants, contact your prescriber. 4. Yellow in the outer corners of the whites, in natural light. Liver function test today. 5. Sectoral redness in one area of one eye, recurring, not responding to drops. Rheumatology referral. 6. Pull the lower eyelid down. Inner surface pale or white on both sides. Complete blood count. 7. One pupil noticeably larger than the other. One lid drooping, and this is new. Any accompanying headache, visual change, or weakness. Emergency care, not an office call. What you just looked for in your eyes, low hemoglobin, compromised circulation, B12 deficiency, these same processes have another way of announcing themselves, one that most people feel in the middle of the night and have been told is simply part of getting older. Something wakes you, a cramp, a spasm, sometimes severe enough to get you out of bed. You have been managing it with stretching or a banana and hoping it passes. The next video covers what your legs are actually trying to tell you when that happens after 60, what the body is running short on, and why the solution most people try addresses the symptom while missing the cause entirely. Watch it now. And if you are not subscribed yet, do that first so you do not miss what comes next.